Hi, my name is Jason Schultz with the Steinberg Institute. We're a leading nonprofit in California dedicated to advancing sound mental health and substance use policies. I'm honored to be joined by Dr. Shai Rab today. Dr. Rab leads the LA County Street Team dedicated to provide mental health care services to the unhoused. The team brings physical and mental health care services to folks where they are, sidewalks, hotels, underpasses, instead of trying to get them to come in for treatment. It's an innovative program, it's expanding, so we wanted to hear more about it. Can you give folks an overview of how the program works?
So HOME stands for Homeless Outreach and Mobile Engagement. The HOME team is a specialized outreach team that provides field-based services that include treatment, housing support, outreach, benefits establishment, and what I like to call large-scale system navigation, because individuals who are living on the streets, experiencing living with a severe mental health condition, they need someone to guide them through the system. And that's what the HOME team really does. We serve individuals who are 18 and older, and oftentimes the individuals are experiencing such intense mental health symptoms that they are not meaningfully providing for their food, clothing, or shelter, not really advocating for their needs, and really trapped despite resources being available. And that's where the HOME team comes in and provides intensive services to really lift people out of that environment and get them into safe community living.
And when you say lift them out of the environment, how important is the environment in terms of their mental health condition?
So that is an excellent question. This is where the essence of street psychiatry comes in, because in order for me to provide care to someone who's experiencing homelessness and living with a severe mental health condition, I need to understand the realities of their living condition. That's not something you can do in a hospital. That is not something you can do in a clinic. You need to be next to them to figure out what exactly, where are the roadblocks over here. So street psychiatry is a component of the HOME team. The HOME team does a lot. We are a multidisciplinary team. We have social workers, community health workers, substance use counselors, and then medical staff with nursing, psychiatric technicians, and psychiatrists. So street psychiatry is a small component, but all of the work is being done within the realities of someone's living condition, so you can truly figure out what the clinical indications are. That's what it takes to lift someone up out of that environment that is really limiting a lot of their options.
You've been at this for a few years now. Tell me about the challenges you've faced. Tell me about what you've learned. Obviously, you're doing something right. The program is expanding.
That is right. I joined the team in 2019. That's kind of around the time when outreach was undergoing a metamorphosis. There was general outreach. This was mainly done by social workers, outreach workers, substance use counselors, providing more case management, linkage, benefit enrollment, and maybe some triage. But there was no real included treatment. When that metamorphosis took place in 2019, that's when medical and psychiatric staff began joining the ranks. And that's when I came in, and I was the first full-time street psychiatrist hired by the Department of Mental Health. At that time, street psychiatry didn't really exist. What it really is taking traditional psychiatry and adapting it to the needs of someone who was living on the streets. There was no infrastructure back then. And over the 3 years that I've been with the team, we have really developed a way of delivering psychiatric services and outreach services and housing services jointly on the streets. The lessons that I have learned is that there was no infrastructure for all of these things to happen simultaneously. There were individual entities that were doing this, but there wasn't a synchronized approach that could really meet all of these needs in unison. And that's what the HOME team really is. More so than a team, it's a way of doing things. And I call the HOME team the white blood cells of the mental health system, because they're going and finding out where things need to be fixed, how can we do things better? And we built a model of care that has tried to overcome many of the roadblocks that are faced by homeless communities, because the system doesn't have it's almost like it wasn't designed with their needs in mind, but those needs are very real and they need to be addressed.
The way you describe it sounds like what we often talk about here at the Institute, which is our systems of care are fragmented. You have different agencies involved, you have different organizations, private, public, different ways of paying for things. You seem to be right on the tip of that spear, if you will, right? You are on the front line of seeing how everything is fragmented, from housing to insurance to healthcare. Are you feeling better about that? Are you seeing changes as folks talk about that?
I would put it this way. I think what at least I've spent the past 3 years doing is identifying where change is needed. How are things even happening? And street psychiatry is interesting because you get to see the manifestation of policy, in vivo, on the ground. How is this, this decision was made, upstream, downstream. This is what's really happening. It's taken it. Yes, being on the tip of the spear, identifying the areas that need to be changed, and then what can we do to pivot and overcome it? That's what basically we have been doing for the past 3 years. But once the secret is that along the way, we found people who share the mission, who share the values, who share the same belief that we can be better. The system can be molded into doing what it's supposed to do, as long as you can match each other's perspective.
In spite of the challenges that you face with all the fragmented systems and the daily challenges that you meet on the streets, I'm sure you've had successes. How do you measure success?
There are so many ways to measure success. One of them is you can use your clinical outcomes. How many people did we house? How many people did we get on medications? Are we moving people fast enough? Are we hopefully prolonging life? On a more personal level, though, for me, success is connecting with human beings who have feelings of alienation, disconnection, isolation, and being a friendly face and showing them that we care, that their needs are important, they matter. To be able to transform, to build that connection with even if it's one person, to build that connection with that human being and transform their lives. I think that when we call them transformations on the home team, where we don't treat people, we don't house people, we transform lives. That's kind of how we focus on it. And if the before and after is sometimes so profound that it kind of replenishes my faith in humanity when that takes place. But there is nothing more. For me, the ultimate success, though, is I can call a family member and saying, "Hey, I found your sister. I found your son. They're alive. They're well. Would you like to talk to them?" Like, to me, and when reuniting families, we've done it. The home team's done it across the globe. We've flown an individual back to Japan and was trapped in little Tokyo. There was so many things that I think real successes. I think the home team is just. I think it shows the best of humanity. That's how I measure it.
You bring up an interesting point there. Los Angeles is a destination for people from around the globe, and not everyone ends up with a success story when they land there. And so I'm sure there are many families all over the world who wonder whatever became of their child or their loved one. Yes,
it is. It can. I think the streets sometimes can sound like it's a hopeless place, but there's a lot of work where you can truly make meaningful impact in people's lives, and there is hope to be found anywhere you look. And we're trying to inspire people to come join our ranks and really do this hard work. But yeah, no, there's a lot of good that we've done and that we can keep doing.
We mentioned LA and the uniqueness of Los Angeles, certainly a homelessness crisis there. So, your work is needed. And we have a homelessness crisis across California. What would this program look like in other communities around the state? Could it be expanded?
Absolutely. Like I said, that the home team is more than a program. It's more of an approach. It's a way of approaching someone's needs. And as a psychiatrist, a lot of my training is about medications and diagnoses. But when you come to the realities of the street, you realize that, Medicaid treatment is important, medical care is very important, but if you don't have your basic needs met, something as simple as housing, it all kind of goes out the window. And so that's why for street psychiatry, the approach is, bring all of your excellent medical and psychiatric expertise to the table. But what's the end goal? The end goal is to move someone into a stable living situation so they can have a foundation to thrive. And that idea, that way of approaching someone's health is what can be shared. Now, do you need to have a team like the home team that can be integrated with traditional mental health services to make that a possibility? Absolutely. And what it would look like if the home team concept was expanded is that the traditional mental health system would realize the need for a field-based component that was integrated with traditional services with a lot of training and education. And I'm not just talking about education in a lecture, exposure to what the realities of field work look like. So that way, when you're sitting in a structured setting like a hospital or a clinic, you have practical knowledge of how to structure your interventions to maximize success beyond your walls.
You mentioned the different settings, and most folks think of psychiatry, the psychiatrist's office, the clinical setting. You've certainly learned a lot of things, I'm sure, being in the field, but learned a lot of things that could be applied if you were to take this approach in other places across the state, or even just in a general sense, I imagine.
Absolutely. That's what happens. What I had to do with street psychiatry is, first of all, street psychiatry, I like to call it it's a team sport. It involves all of us having a unified, every single member of the team is critical. So our social workers, our outreach workers, our substance use counselors, our nurses, our psych technicians, the psychiatrists, we all have a role to play, and we integrate all of our specialties and our skill sets with a common goal. What I learned is that, especially with people who are experiencing homelessness, your treatment plan has to work for them. They shouldn't have to work for your treatment plan. Therefore, a lot of the time, what we do is actually developing a strategy for the treatment plan to be executed. Like, how is it actually going to carry out? Like, for example, if I want to prescribe medication, I'm not just going to go and, hand a prescription over to someone who's barely able to find shelter and food and expect them to, now they're going to go take their medications and become very, very stable. No, we actually develop a medication delivery support plan where the team will go out every single day and deliver medications in specialized bubble packs with the individual's name and everything. So our treatment can work around their realities rather than adding one more thing to the many different things that an individual has to focus on.
Well, that's an interesting point. We hear so much talk about meeting people where they are in a general sense, and you truly are physically, but also, you're meeting them where they are mentally, and you're meeting them where they are with their individual daily needs, in the scenario that you described there.
Yeah, our entire model is based around let's make this journey as easy for you as possible. You see, I'm your doctor. I'll be here. You have a question? Here's my card. Call me. I'll be out here to see you tomorrow. Do you want any clothes? What are your hobbies? Do you like music? You want me to get you a radio? Whatever you need so I can build a connection with them. So I can so I can really help them navigate the system. I think the thing that takes the longest is to build that human connection. People are oftentimes so disconnected, and psychiatry doesn't typically have the best street cred. So sometimes you really have to kind of overcome any past traumas from treatment. You know, there's a lot of people who have been hospitalized involuntarily, been put in restraints, been given involuntary medication, and here comes another psychiatrist trying to do the same thing. So it's very important that I spend a lot of time building trust with an individual, and once that's done, really kind of making my treatment plan work for them, so that way they can just focus on fostering trust with my team.
And housing must be key here for you.
That is the goal. The goal, it's, if I can get someone into housing without medications, great. I have seen people with severe mental health conditions become 80% better with housing, just because the severe weather conditions aren't just wearing them down physically. So housing is always my goal. One of the things is, if you look at the traditional mental health system, people with severe mental health conditions and chronic homelessness, they aren't able to connect to outpatient clinics. They have a hard time getting into licensed residential facilities because you need a psychiatrist to complete the paperwork for you. You need to get the labs and the medical clearance to get inside. So those two levels of care are out. You oftentimes cycle in and out of a psychiatric emergency room or an inpatient unit, what's also called your revolving door of treatment. And then you are discharged to the street with the hope that the outpatient world will take care of your needs, but there really is no outpatient level of care if you're experiencing street homelessness. But that's what the home team does, is that it creates this primary recovery pathway to permanent housing and community reintegration, where if you do pick up someone who's getting discharged from the hospital, then it's an integrated system where there is a level of care that is picking up the baton for someone who's coming out of the traditional mental health system, that's integrating and synchronizing care. That's what the home team does, and that's what is needed to really bridge that disconnect between the outpatient world and the streets.
There can be a sense of hopelessness that exists in this space when it comes to homelessness in California. Folks don't see the light at the end of the tunnel for folks who are living on the street. You have a positive attitude about you here when talking about this. What keeps you going personally?
Like I say, the issue is so large that if you start getting caught up in everything that can go wrong, that can be a very dark place to go to. What keeps me going on are the individual successes that we've had. They've been amazing. I mean, we've turned around people's lives, and the program is also growing and scaling up, which means that the momentum that we got with our first cases build, and it spawned more. Our brand got bigger, more referrals started coming in, more people are realizing the need for having a field-based component integrated into their mental health ecosystem. The growth of the program, the expansion of street psychiatry, the integration of education. I have residents that are coming in. The new generation of doctors are coming and learning on the street. These are all, to me, such good indicators of change, of the direction we're going in. So it keeps me going. And then my personal hobbies: mixing music, watching TV, binging Netflix, the usual stuff. like a normal person. I don't just sit here and read books all day long in medical journals.
You do some DJing on the side, is that correct?
Now you heard that? Yes, I do. I like. I'm a huge music. I'm an amateur. I'm not professionally trained at all, but I love house and techno music. So yeah, I have a mixing setup. So I have some fun. I actually do it for local venues, and sometimes I'll DJ for charity, and we'll get some free meals. If I DJ at a restaurant, we'll have them give some free meals to the people outside who are experiencing homelessness.
Oh, that's fantastic. Well, I wish we could hear some of your beats.
Maybe one day.
Before we wrap things up here, what's next for the street team?
So The DMH home team has developed a model that is effective in really helping individuals with severe mental illness who are experiencing chronic street homelessness really get into stable housing and achieve community reintegration. But that's just, that's the model. Now we need to scale up the model. We need to scale, integrate, educate, and start developing this approach. And it's going to look different everywhere we go, but incorporating the lessons we've learned, the innovations that we've developed, and sharing them with the rest of the nation to see if they help. I think that's the growth. The hashtag will be growth and advancement.
Dr. Rab, thank you so much for spending some time with me today. We're wishing you the very best in LA, giving folks hope in that community. Thank you for your time.
Thank you so much.